And good morning. I'm Dr. Kim Williams, Chair of Medicine here at University of Louisville. And it's my pleasure this morning to introduce to you the man who does everything. Okay. A lot of people talk about the triple threat doctor, someone who can actually do teaching and a high level of clinical expertise and research and publication. And we have one for you today. Dr. Shahab Ghafghazi is giving our medical grand rounds. He'll be talking about the forgotten valve, a contemporary approach to tricuspid regurgitation. Something that's dear to anyone in my era when we used to say, oh, you don't need a tricuspid valve. The surgeon would just cut it out after endocarditis. That was horrible. And you're going to tell us all so much of why. But in terms of his background, originating from Iran, Dr. Ghafghazi has been here at University of Louisville for a long time. He did his general medical training in the UK and then internal medicine residency at UT Southwest. Before his cardiology fellowship here, he actually did a lot of extra training in non-invasive imaging, particularly nuclear cardiology and echo. And he has worked his way up to associate professor here. But when you look through what he's been accomplishing here at University of Louisville, it's pretty amazing in terms of the honors and awards for teaching the so-called citizenship in terms of being involved in so many aspects of our university medical center with committee assignments, his education, his teaching, and research contracts and publications. Really proud of all that you've accomplished, and I'm happy to come up and be able to brag about you for a little bit, and looking forward to everything you have to say.
I appreciate it. Thank you. Thank you very much for the kind introduction. So valvular heart disease is, a topic that outside cardiology, in the realm of internal medicine is really not much people don't pay attention much to that. And I think I want to perhaps attract people's attention to, what's happening now today. We're going to talk about tricuspid valve, which is truly called the forgotten valve. Because for many, many years, we really didn't have much to offer to patients with tricuspid regurgitation, and things have started to change. So I want to show you some of the stuff that's happened and some of the stuff that we actually do here, so that when you see your patients in clinic, you are able to start paying attention to that, and perhaps find patients that could benefit from some of the things that we can offer them. Obviously, I won't be able to cover everything, but I'm going to try to cover most of the stuff that you'll probably come across with regards to tricuspid regurgitation. So I'm going to show you 3 vignettes, and there's a reason for that, because these are arguably 3 flavors of tricuspid regurgitation that you would mostly see. There's probably 10 flavors, but let's start with 3. So here's the first one. So this is an atrial secondary tricuspid regurgitation. And I'll go over exactly what we mean by that. So this is a 78-year-old woman, long-standing atrial fibrillation, preserved ejection fraction, comes with progressive lower extremity edema, early satiety and fatigue, no orthopnea, no pulmonary congestion. You examine them and you notice prominent V waves on their JVP exam, some hepatic pulsatility and hepatomegaly, a soft polysystolic murmur at left lower sternal border, which is augmented with inspiration. And then you get an echocardiogram. You have severe tricuspid regurgitation with some annular dilatations, although the leaflets seem to be normal. There's severe right atrial enlargement, but RV, right ventricular function, is normal. Ejection fraction on the left side is normal. They have elevated NT-proBNP. So this is the atrial tricuspid regurgitation. Here's the second one. This is a 68-year-old man, has ischemic cardiomyopathy, EF of 30%, less than 35%. You get an ICD. That's what he has. 5 years ago, has come in with progressive abdominal distension, fatigue, and right upper quadrant discomfort. Again, you examine, you notice the V waves. You have some ascites. You have pedal edema. Again, nothing in the lungs. And another echocardiogram, and you see the same thing. You have severe TR, but it looks like it's the ICD lead that impinges on one of these leaflets. So in other words, it doesn't let the leaflet essentially function properly. And you look around in your clinic, you have a lot of these patients with devices, pacemakers and ICDs. And so this is actually not that uncommon. So you have moderate to reduced RV function. you have no pulmonary hypertension. You get a CT scan to kind of maybe better detect, define what's going on, and you notice that there is the lead is essentially putting pressure on the central part of the septal leaflet. And here's the third one. This is a ventricular secondary tricuspid regurgitation. So 72-year-old man, ischemic cardiomyopathy again, has had a cabbage, comes with progressive dyspnea, NYHA class 3, edema, early satiety, despite uptitrated diuretics. Again, you have the V waves on exam, you have the holosystolic murmur, but this time you have crackles, you have in the lungs, so the lungs are also wet, some pitting edema, hepatomegaly, again, severe TR. This is called functional TR. You see the annular dilatation. You also see ventricular dilatation and leaflet tethering. And tethering means you have dilated chambers, and so these leaflets are meant to actually be able to coapt within certain distances. And now things are dilated, so they struggle to reach essentially each other and form a nice coaptation. You have some secondary pulmonary hypertension. Of course, EF, as we said, is on the lower side because of the ischemic cardiomyopathy, BNP, and so on. And of course, you confirm all of this with cardiac MR. It shows RV enlargement and hypokinesis. Okay, so I'll go over these again at the end of the talk and show you what options we have to offer these patients. But this is essentially 3 flavors of this sort of secondary type of tricuspid regurgitation. So here's the anatomy of tricuspid valve. So you have essentially it's called tricuspid. So an anterior leaflet, a septal leaflet, a posterior leaflet. Funny enough, it's actually 70% of the time more than 3 leaflets. You can actually have up to 6 leaflets, but generally it's been called tricuspid valve. The anterior leaflet is the largest, the most anatomically constant. The other ones vary in size and position. Sometimes, as I said, you have 2 posterior and 2 septal. The tricuspid annulus is non-planar. It's in fact the same with mitral annulus, and I'll show you some images of that. It does have dynamic structure. In fact, it contracts the actual annulus. So you don't think about that as a skeleton. It actually contracts with systole. There are papillary muscles, essentially 1 per leaflet. And the chordae are attached to those papillary muscles. But on the right side, RV, the chordae can be directly attached to the RV free wall, as opposed to what you have on the mitral valve, whereby the chordae are only attached to the papillary muscles. So here are the 3 leaflets. Now, this is an image that you can only get with TEE inside the stomach. This is called a transgastric view. And as you notice, essentially with the sample over here and the TEE, here's the septal leaflet, here's the posterior leaflet, and here's the anterior leaflet. Now, when you're in the stomach, you see the liver over there, right? So the posterior is the one that's essentially close to the liver. Here's the aorta. Aorta is an anterior structure, so this would be the anterior leaflet. This is that papillary muscle, anterior papillary muscle. This essentially separates the anterior leaflet from posterior. Now, I have this line here. This is the coaptation line, and it is important later on when I explain to you how we do essentially these interventional procedures. We try to respect this line very much in order to be able to have a stable, essentially, triclip applied. So the diameter of the valve is about 31 millimeter, and it is, we call it significant dilation when it gets above 40 millimeters. And is associated by that time with progressive tricuspid regurgitation. So here's that saddle shape that we talked about. Now, this view is essentially you're looking from the side. So you have the anterior here and posterior. So these are the 2 high points. And the low points are the medial and lateral sides. So that's normal, right? Now, as you get a dilation of the tricuspid annulus because of tricuspid regurgitation, or in fact other reasons, for example, atrial fibrillation, right, which causes essentially dilation of the right atrium. That's that atrial type of tricuspid regurgitation that we'll explain, go over a bit more down the line. So as this process happens, what's going to happen is that the annulus is going to become flattened, right? And it starts with the posterior, in fact, high point. It goes down first. and then the anterior hypoid goes down. And you can see that on the graphs over here. The annulus essentially becomes larger, becomes more planar, and becomes circular. And obviously, this is pathologic, and this is going to be associated with tricuspid regurgitation. You can see on this graph that as the essentially area increases, meaning the annulus becomes larger and larger, you lose that height on the annulus, right? Which is, again, something that is pathologic and is associated with tricuspid regurgitation. Now, how does the annulus expand? So again, this is, you're looking at what's called a surgical view of the heart. So this is, assume you've essentially opened up the chest and you've removed the atria, right? So what you're seeing is the tricuspid valve here, the mitral valve here. So when the tricuspid valve wants to expand, the annulus wants to expand, it expands essentially from this side. And you can see that over here. So that's essentially the direction of the expansion. I can probably use this laser point here. This is the direction of the expansion as you see over here. So in other words, this is the RV free wall. So, and it makes sense, right? It can't expand into the left ventricle to the left side, right? The left side is essentially the left ventricle. So there's not much space over there to expand. So the expansion essentially happens here. And notice that this becomes, as I said, more circular, right? So a normal tricuspid valve has essentially a larger anteroposterior diameter compared to mediolateral diameter. And as the expansion happens, for whatever reason that is, you're going to get a more circular, and of course, it becomes sort of flattened and, it becomes more planar. Right. Here's now we're done with anatomy. Let's move on to the epidemiology and the burden of disease. It is not actually that uncommon. Again, it's the forgotten valve, so you don't even think about it. But 1.6 million Americans have that. Moderate, we're talking about moderate and greater TR. So in fact, if you look at mild TR, it's even more. In general population, about 5 to 6% of the population have moderate TR, and severe about 1.5 to 2%. Now do the math, 2% of 350 million people. That's a pretty large number. As people get older with age, this number, a moderate severe, can go up to 4%. However, currently, and probably the number has not changed much. About 1% of people just get definitive therapy. So there's a lot of work that can be done, and now we're starting to have the tools essentially to accomplish that. How about the demographics and risk factors? There's a strong female predominance, 4 times higher than men. It is associated with advanced stage, AFib, HFpEF, and pulmonary hypertension, whether it's primary or secondary. And that makes sense. Again, if you think about it, these are the things that make all these chambers dilate, right? So heart failure is a major one. Atrial fibrillation is a major one. Pulmonary hypertension, obviously much less common if it's primary, but still causes expansion of the right-sided chambers. Of course, you see that in female because you also see a lot of HFpEF essentially in the female population. So this is the classification. Now, with the vignettes that I started, I talked about the secondary, the atrial versus ventricular, and then versus lead induced, right? So that's essentially what you see on this side. So about 90% of the cases are essentially those three vignettes that I showed you, right? So, the secondary tricuspid regurgitation is essentially because of remodeling. Now, remodeling has a ventricular form, has an atrial form. So the atrial form is mostly associated with atrial fibrillation. That's essentially arguably the only thing that causes the atrial form. Now, HFpEF and RA myopathy and so on, correct, but atrial fibrillation is really the one that you want to pay attention to. On the ventricular side, it is essentially predominantly a secondary complication of left-sided disease. And of course, it can be because of pulmonary hypertension, primary pulmonary hypertension, that group 1, WHA group 1. But obviously, that's much less common than the left-sided heart disease, right? Whether it's valvular, whether it is essentially heart failure. So this is 80 to 85%. There's another form of secondary TR. This is CIED. This is cardiac electronic devices, essentially. So they call it lead. That's much easier to say, CIED. That's essentially lead-induced tricuspid regurgitation. So that's like 5%. And that has some forms. I'll go over that. And of course, the primary is the causes essentially mentioned over here. So prolapse, a flay leaflet, rheumatic, carcinoid, trauma, endocarditis, congenital. For a few years, we had a lot of endocarditis. Fortunately, we see a lot less of that compared to perhaps between 2015 to 2017. We were seeing a ton of it. We see a lot less of that, maybe maybe because of the changes. I don't know if it's because of what is this thing that we do for narcotics?
Suboxone.
Yes, maybe because of that. So whatever it is it people are smarter and do less IV? We certainly do see a lot less of endocarditis. But essentially, these are the endocarditis. These are the primary types, which is about 10 to 15%. So I'm going to go over a few of the primary types and then focus on secondary, which is essentially the major talk for today. So TR can be secondary to mediastinal radiation and other fibrotic processes. So valvulitis is essentially the phenomenon that's caused by radiation, and it causes then fibrosis and calcification, as you can imagine, with any other form of inflammation. As the inflammation heals, that's what you're going to get, usually about 5 years or more after the radiation. So that's common when you see cancer patients post-radiation. Rare in America, but endomyocardial fibrosis is something that you see in tropical Africa. With essentially fibrosis of the papillary muscles. This is also fairly similar to what you see with drugs. Now, we see a lot less of this, but in the old days, famous fen-phen or drugs, anorectic drugs that were used for weight loss. And of course, I've mentioned a bunch of other ones here that you can see. Again, not usual. We don't see a lot of this, but these are some of the primary causes. Here's an example of the carcinoid TR. What you're going to get is essentially a frozen valve and a significant amount of regurgitation. And whenever you see a triangular regurgitation pattern, that's essentially suggestive of severe tricuspid regurgitation. And you can see essentially the valve is completely open. Here's an example of a carcinoid. So you can see that this leaflet and this leaflet are essentially frozen. And you see a significant tricuspid regurgitation here. Okay, so now that's a little bit of a primary. That's the 10 to 15%. Obviously, as I said, what we saw for a few years ago was vegetations from endocarditis. We still see that sometimes. That's essentially a whole different problem. I'm not going to address that today, but let's focus on the secondary tricuspid regurgitation. So we have two forms mostly of secondary tricuspid regurgitation. There's this atrial form, and then there's this ventricular form. And of course, like everything else, there's an overlap. Now, atrial form is essentially atrial dilation. As I said, it is predominantly because of atrial fibrillation. And the atrial fibrillation is going to cause the right atrial enlargement, which in turn will cause the annulus dilation, right? Yeah. And it is disproportionate to between the left atrium and the right atrium and right ventricle. It's sort of Mickey Mouse pattern on one side. So big ears, right? But sort of small face. So RV is normal. You have some remodeling, but there's no systolic dysfunction. There's not much dilation. There's not much tethering. That tethering happens when the right ventricle expands. And so because you don't have that, you don't see a lot of that. So think about, again, atrial fibrillation, that's atrial secondary. How about the ventricular? As we said, it's because of ventricular dilation, which is in turn most of the time because of left-sided heart disease, whether it's valvular or heart failure. It can also be because of primary pulmonary hypertension. So the mechanism here is mostly leaflet tethering. Because of that dilation of the right ventricle, now these leaflets are not able to essentially coapt well. And so despite the fact that it's predominantly right ventricular, you will see some, right atrial enlargement, but you don't have that disproportionality. So notice here, again, right atrium is very large and right ventricle is normal size. Here, they can be proportional, but you realize essentially the right ventricle is pretty, abnormal. So you have RV dysfunction, you have RV dilation and hypertrophy. You have some, again, a left atrial and annulus dilation. You can have significant pulmonary hypertension, whether that's because of a secondary PH from left-sided heart disease, or if it's because of primary PH. Again, similarly, you can have ejection fraction less than 50%, again, left-sided heart disease or valvular heart disease. And this should be VHD. This is their mistake, I noticed that. So that's from Jack. In the text is actually said, accurate is VHD, but here is HVD. So here again, you'll see that again here. So that's the atrial form. Again, think about AFib. Ventricular form, think about heart failure, valvular heart disease, mitral, aortic, think about pulmonary hypertension. Now, I keep repeating that because I want you to kind of have these, forms in mind, because you make a decision make a difference how we make actual decision about treating these patients. How about the leads? That's the 5% of TR. It is actually, the prevalence is actually increasing, because now as population gets older and you have more comorbidities, you're going to have more pacemakers and more ICDs and so on. So you see a fair amount of this. This is a study that looked at essentially lead-induced tricuspid regurgitation. The leads were placed about 72 months on average, but anything from 2 months to 228 months. There are different mechanisms involved. In this study, they noticed a lead impingement for 16%, adhesion 14%, entrapment 4%, and perforation about 7%. There's also this other mechanism, wasn't reported in this particular study, but once in a while it can be because while they're trying to remove the lead for, let's say, endocarditis, you cause essentially a rupture either to the leaflet or in fact to the valvular apparatus that can cause this. Now, how prevalent is that? You have there's probably about 20 studies, and you can see the range is very variable. Why? That's probably because of technical ability of different people doing different things. So obviously, high volume centers, they're probably better at placing these devices. Lower volume centers may have more difficulty doing them. Here, even in the US, if you go to small towns, you see a lot of sort of non-electrophysiologists placing these leads. And so that can essentially be associated with more complications than if it's done by an electrophysiologist. So it's a significant variability in terms of the prevalence of, but so you can imagine 45%, 1 out of 2 leads that, in some centers are placed will cause essentially tricuspid regurgitation. So this is what we're talking about. So ideally, you want to have your lead. So this is, again, your tricuspid valve. This is the anterior septal posterior leaflets. Ideally, you want to have your lead right in the middle, or essentially in these corners, in a way that they don't essentially interfere with the mechanism, with the function of the valve. You don't want to have them essentially attached to the leads, because if there's attachment, the leads can't coact well. And you don't want to have them impinge on the leads. Now, I have some examples to show you what we're talking about. So obviously, this is an unfortunate patient, because you can see a sample here. And here's an example of lead attachment. Here is essentially an example of lead attachment. And notice that this leaflet over here is attached to this ICD lead, right? And notice how much color you see over here. And so this is the lead over here on this 3D rendering. You think these leaflets come together, but that essentially, malcoaptation you see right over here is essentially the source of this massive tricuspid regurgitation. So here's an example of adhesion. And you notice that because you realize, okay, so I can't see this leaflet separate from the actual ICD lead. Here's another one. Again, I'm showing you the still image. I'm going to show you the clip in a second. And notice again, this lead is attached to the septal leaflet over here. And so this is that adhesion mechanism. Now, impingement mechanism. Again, I'm going to show you the still image. So the lead is over here. And now this is the image. Notice this lead. You have this wide gap right in the middle because it's essentially putting pressure right in the middle of essentially your. Now this is the TEE. So this is the posterior leaflet over here. That's the septal. That's the anterior. So that lead is sitting right over here and putting the pressure right in the middle, causing essentially a lead impingement. Here's another example of impingement. Now you may say, well, I think this lead is maybe attached to the leaflet over here, but notice that leaflet is actually able to separate, but it's just not able to come together with this other leaflet over here. Now, does it matter? It does matter in terms of what you're going to do, and I'll show you an example at the end when we talk about treatment. It does matter that you figure out what the mechanism is because it may make a difference as to how you essentially approach this. Here's an example of a significant complication. So this is a perforation. So that's essentially the lead. You can see a lot of color over here. And here, essentially, the same patient going to the OR. And notice that the lead is essentially causing, from here, notice that lead is essentially perforating the leaflet and going through the leaflet. That's unusual, fortunately, about 7% in that one study. So lead adhesion and impingement are the most common causes, but these things are, perforation is something that can also happen. Of course, that most of the time will need surgery when it comes to perforation. Okay, so we looked at the causes, right? So primary, secondary, and we said secondary has the atrial form, the ventricular form, and of course, then the lead induced, right? So then what happens? So you start having TR. It's a vicious cycle, like what you see in heart failure, what you see in pulmonary hypertension, what you see in valvular heart disease. It unfortunately keeps perpetuating itself. And here's a graph that shows you the mechanism. So TR causes a bit of RV dilation, which causes annular dilation, which causes malcoaptation, which causes more TR, and on and on and on, right? So this process happens. Now, it may take years, and so you notice we have a classification here from mild all the way to torrential. It used to be before advent of the new therapies that now we have available, mild, moderate, and severe. However, now the data suggests that in fact, as it gets worse, the prognosis gets worse. So it makes sense to actually have this expanded sort of classification, and so that we can grade these patients appropriately. So TR typically evolves over the years, silently, very slowly, insidiously. The secondary TR, which is at 80%, or 80 to 85%, progression is by chamber remodeling, as I showed you. It is mostly not intrinsic valvular disease. The intrinsic disease is either that primary, that carcinoid, the vegetation, flail leaflet, and so on. Or, perhaps you have a rupture by a lead or something. So that's when the leaflet itself gets involved. But the secondary TR, which is the 80 to 85%, is always because of chamber remodeling. So the leaflets by themselves are actually fine. They just get pulled apart because of the annular dilation or because of the ventricular side, which causes essentially that tethering of the leaflets. They're getting pulled apart from each other from the subvalvular apparatus, and so they can't go out well. So, patients are frequently asymptomatic until they have significant annular dilation and, in fact, RV volume overload, and then they start to have symptoms. Again, not indifferent than heart failure. I mean, how many times have you seen a patient arriving with ejection fraction of 10% for the first time with the emergency room? It's the same, unfortunately. We have a lot of reserve in our bodies, so that is good, but at the same time, it probably good to have symptoms earlier so that people can present. So by the time TR clinically is recognized, significant RA and RV dilation usually is already present. So how about those two different subtypes? So atrial, as we said, is mostly AFib induced and is associated with loss of annular contractility. As you said, you have loss of atrial contractility. So the same thing happened with the annulus. As remember, at the beginning of the talk, I said annulus contracts by about 25% during essentially atrial contraction. It's more common in elderly women that have AFib and, of course, preserved ejection fraction. On the other hand, the ventricular form, the ventricular secondary TR, it happens on the, in the context of mostly left-sided heart disease, also pulmonary hypertension, and the severity parallels the degree of RV dilation and tethering. So progression is a little bit different, right? So the atrial side, it's the right atrial dilation, and then annular dilation. The ventricular side is the ventricular dilation. The prognosis is grim regardless, right? It starts with mild. If you look at the mild TR, all-cause mortality is increased by 30% compared to peer population. By the time you get to moderate to severe, that's 2 to 3 times higher long-term mortality, and untreated severe TR is essentially a death sentence. It's not any different than what you see with heart failure. It's not any different than what you see with severe COPD, right? So 70% 4 years is, heart failure in general, about 50% 5 years. And so this is even worse than that. So untreated prognosis is not good at all. Here's essentially an old study, 2004. This is essentially all COM-TR, and notice no TR all the way. This is Kaplan-Meier curve, severe TR. So prognosis is pretty grim. So these are days, right? So 1,000 days, about 3 years, right? Maybe 3.5 years. And that's 60%, right? So that's a significant drop in ejection fraction. Here's the example of lead induced. So it doesn't matter what causes the TR. You are going to have a bad prognosis. Now, there may be a different, a difference in terms of the type of the TR that you have. So it is related to, and I think I have a slide, moving forward that I'll show you. One of the things that determines the prognosis is the RV function, right? And as you remember, the ventricular TR has more RV dysfunction, and because that's a major prognostic factor, that's the type that you're going to have a worse prognosis compared to atrial TR. Okay, so let's go to clinical symptoms. In mild and early, often asymptomatic. You may have some subtle symptoms: mild exercise intolerance, fatigue, abdominal fullness, and it usually is detected incidentally on an echocardiogram. You will have a soft holosystolic murmur at the left lower sternal border. Here's a name if you want to know that, Carvalho sign, which is that accentuation of the murmur with inspiration. As it gets more severe, progressive, and eventually severe, symptoms become more significant, more fatigue, more exertional dyspnea, reduced exercise tolerance. Pretty standard cardiovascular symptoms, cold extremities, lightheadedness. Of course, you can get all the way to cachexia that you see with advanced heart failure. On exam, you see essentially prominent V waves on examination of the JVP, hepatomegaly and hepatic pulsatility. If you've seen severe TR, you examine those patients, sometimes you see pretty prominent hepatic. You don't even need to do anything. You just put your hand on essentially right upper quadrant, and you'll notice something is pulsatile there. Of course, peripheral edema and a murmur and so on. So symptoms are pretty standard sort of cardiovascular symptoms. And in terms of prognostic factors, as I said, RV function is by far the most important prognostic factor. And that's why the RV secondary TR has poorer prognosis compared to atrial TR. There are other factors. Obviously, the severity of TR matters. The RA, the annulus dilation, presence of pulmonary hypertension, presence of systemic conditions, again, makes sense. Left-sided disease, atrial fibrillation, functional class, and timing of therapy. None of this is surprising. I think the one to be aware of is the RV. Mind the RV. Here's essentially a graph. This is essentially all comers with severe tricuspid regurgitation. And your stage 4 RV disease, as RV disease progresses, your prognosis essentially worsens. And again, this is the atrial ventricular, as mentioned. It makes sense. If the RV function is what matters, the ventricular form is going to have worse prognosis compared to the atrial form. Okay, so grading, I'm not going to do a lot of echocardiography here, but essentially here's an approach to grading severe tricuspid regurgitation. It is important to do what's called multi-parametric, meaning that we have multiple ways of measuring this. It's important to measure as many ways as you can, and essentially do your best to come at an accurate grading of the tricuspid regurgitation, because that essentially changes the approach to patient's treatment. One measure that I'm going to highlight here is called vena contracta. And the idea beyond vena contracta is essentially measuring the diameter of that regurgitation orifice. Now, for simplicity, assume that the orifice is like this, it's round. And so you measure the diameter and then you can measure a surface area. The problem with that is frequently that orifice is not like a circle, right? So you measure the diameter, and this is a good one. At least the one I have over here is triangular. Sometimes it's essentially completely, shapeless. It is essentially, a serpentine cylinder, right? So nowadays, if you can do what's called a 3-dimensional vena contracta, which essentially what it means is, so here's the regular vena contracta. You measure the diameter. You assume the orifice is round, so you can measure the surface area. And so we have numbers that says, such and such number essentially is mild, moderate, and severe. With 3-dimensional assessment, 3-dimensional echocardiography, you can measure. So here, as you can see on this example, it's been measured like this. So you do what's called planimetry of this orifice, and you come up at a number which is completely different if you were to just measure this with 2D and assume that this is a round orifice. This is something you can actually do even with POCUS. If you do a Doppler, and a lot of the machines that we have for POCUS have a Doppler capability of the hepatic vein. So you you essentially image the IVC. So assume your IVC is essentially your horizontal hepatic vein is going like this, right? So you put your Doppler. What you're going to see with severe tricuspid regurgitation is what's called systolic reversal. So you expect essentially blood flow to be all above the line, meaning they're all going from the IVC to the right atrium. And if you see this, a pretty consistent reversal in systole. So here's your ECGs. So you notice that systole reversal, again, another systole the same, another one the same. This is essentially a sign of severe tricuspid regurgitation. Now, of course, echo is the workhorse of essentially measuring the grade of tricuspid regurgitation. But you can do that with MRI. I'm not an MRI person. All I can tell you is that there are different methods of doing that. So here's one method, here's another method. So in difficult cases that you need to that you're not sure what transthoracic, you can do a TEE, which allows you to get better images most of the time. And of course, you can use more to quantify tricuspid regurgitation. Okay, so we've talked so far about the anatomy, the etiology, the epidemiology, all the symptoms. So, and then of course grading. So let's talk about treatment. What would you do with medical treatment? So medical treatment, in essentially one word, it's going to be medical treatment of heart failure, right? And that's sort of the standard. That is essentially GDMT, best GDMT you can do all day, every day. So that is standard of care. Do we have enough evidence for that? We do not. However, that's expert opinion, agreeable. Everybody agrees. A lot of your TR, as we said, is 80 to 85% secondary. A lot of that is because of left-sided heart disease. So standard. So you treat all of those. So you obviously make sure patients are euvolemic. You diurese them. That's for symptom relief. If you have left-sided heart disease, HFrEF, you do standard GDMT, all that stuff that you are aware of. SGLT2 inhibitors have obviously in HFrEF, but also in HFpEF. And in fact, there's some evidence that in fact in isolated RV disease, they may be helpful. So that's another one. Atrial fibrillation control is very, very important. Obviously, as we said, atrial fibrillation is very predominant in that atrial form of secondary TR. So we prefer rhythm control to rate control. And I'll show you why that is the case in a minute. So you want to essentially be very aggressive with doing whatever you need to do, whether it's going to be antiarrhythmic therapy or ablation, and most often these days ablation, to try to keep people in rhythm, in sinus rhythm. Treat pulmonary hypertension if it is essentially because of COPD. If it is primary pulmonary hypertension, you have to treat that, right? Pulmonary hypertension is going to worsen TR if you leave that untreated. And of course, lifestyle, sodium, Dr. Williams' favorite. Make sure that you have a low sodium. In fact, this is less than 2. Less than 1.2 is what you actually recommend. But lifestyle measures, of course, palliative care in cases that there's not much that you can offer the patients. Very important to make sure quality of life is preserved as much as you can for the time that patient has with their family. So what I said about atrial fibrillation. So here's a study that looked at longitudinally. That's about 700 patients, new onset AFib, followed for about 13 years. 1/3 of them essentially developed moderate to severe TR. Right? And if you develop moderate to severe TR, your prognosis is going to be poor. So this is after severe TR compared to before. This is incidence of death, right? So a long-standing atrial fibrillation, 1/3 of the time causes moderate to severe tricuspid regurgitation. And 10 to 13 years is not a long time. If you have a 60-year-old patient, by the time they're 70, they can have 1/3 of them will have that. So if you notice that TR is developing, you want to be aggressive with that, which is essentially what our field has moved to with atrial fibrillation, because obviously you don't know which one of your new onset AFibs are going to develop, the TR down the line. But the field has moved to being more aggressive with early atrial fibrillation, and this is another reason essentially to do that. How about surgical management? Surgeons don't like to operate on standalone tricuspid valve. So they do it if they are going to go in and do something on the left side. That's the only class 1 you have. So notice class 1, severe TR at the time of left-sided surgery, right? Again, class 2A, mild to moderate TR, again, at the same time, concomitant with left-sided surgery. So if you're going to go in and fix the mitral valve or aortic valve, class 1, if you have severe TR, and class 2A, moderate TR with some, anatomic criteria that I've mentioned to you, right? Now, how about isolated TR surgery? So essentially, left side is fine. Patient comes in with, a symptomatic severe TR. So 2A, if the TR is symptomatic. But if the TR is asymptomatic, so we're talking about severe asymptomatic TR, and in fact, it's a class 2B, right? And notice again, 2A for reoperation if patient is symptomatic. So this is AHA-ACC, this is 2020 guidelines, that's not changed yet. And notice the only class 1s are when you're essentially going to, do left-sided, notice here at time of left-sided surgery, tricuspid valve repair or replacement. Again, asymptomatic severe TR at the time of left-sided surgery, that's always a class 1. But when your 2As are essentially progressive TR that are essentially isolated primary over here, and then everything else is 2B. So why is that? Why do surgeons not like doing tricuspid regurgitation? Their experience over the years has always been that these patients don't necessarily do so well. First of all, there's about 10 to 12% in-hospital mortality. That's a pretty high number. If you look at CABG mortality, that's well less than 5%. So you are essentially saying, okay, 10% mortality. And then, of course, you have studies that show that there is not a big difference between medical and surgical. This is 20 years down the line. This is isolated tricuspid regurgitation. So when you have, there are studies to suggest, obviously, these are all observational studies, but when you see that you're not making much of a difference, then 10% mortality is a pretty high number. Now, of course, they do have, these scales. So, for example, if you use this scoring system, you can have very low risk patients and you can actually take them to the OR. But of course, you can have somebody with, a score of 9 here, or in fact, I would say, a score of probably anything above 5 or above, and you want to stay, surgeons want to stay away from them. And when you talk to surgeons, you'll see that. I mean, they're willing to take low risk patients. They're not willing to take high risk patients for good reasons, because the data is not supportive of that. So this opens up the space for transcatheter management, right? Now, of course, this is all the valves that are in development. The ones that I have over here are the ones that are clinically available. We have TriClip and Pascal are essentially two similar technologies, two different companies. Evoque is a transcatheter valve replacement. We don't have that here in Louisville. We may have it in future. I'll show you some concern with that. They've not pulled the trigger yet. But we have access to TriClip. And of course, these other ones are essentially being developed. So these are divided into 4 categories. So there are these essentially edge-to-edge repair mechanisms, which is all the stuff that you see here. TriClip and Pascal are one of those. There are these annuloplasty devices. As you remember, especially on the atrial type, in fact, also in ventricular type, you have some annular dilation. And so there are devices that are being developed. So in fact, the Cardioband is already, already owns CE mark in the EU, but we don't have it in the US. So it allows you to do a transcatheter annuloplasty, make the annulus smaller so that the coaptation can be more effective. So the annuloplasty, you have the edge-to-edge repair mechanisms. You have this heterotopic valves. Heterotopic means the valve is not in its place. You put them in IVC and SVC, and this is mostly palliative. This is essentially mostly for symptom relief. You don't, change what's happening in the heart with the TEER, but you reduce, for example, the ascites and the leg edema and so on and so forth. So it can be used as a palliative, but again, we don't have any of that in the US right now. And of course, the orthotopic, meaning the actual valve replacement, Evoque is the one that now we have available in the US. Okay, so let's look at the TriClip, the one that we have here. So this is the Tri-Illuminate pivotal trial. So this was a multi-center randomized trial, TriClip versus optimal medical therapy, 350 patients. As you can see, pretty standard sort of patient population, moderate or greater tricuspid regurgitation. They had a complex endpoint. And used a complex statistics, but essentially the win ratio was significantly positive, mostly driven by quality of life. As you can see, KCCQ, Kansas City, questionnaire, cardiomyopathy questionnaire is essentially a questionnaire about the quality of life in patients with heart failure. They had a significant reduction in TR, about 87%, and in fact, moderate or less in 71%. There was no mortality difference, but the study was positive. As you can see here, this is the quality of life. When you compare moderate or less compared to severe or massive, notice that KCCQ is significantly different. And here again, you see these tricuspid regurgitation that's significantly reduced. This is the other one, the Evoque that we have in the US. This is a randomized trial called Tricent, essentially published this year in New England Journal. And very similar outcomes, although this one, the win ratio was a little bit higher. The TR reduction was more significant. And in fact, not only KCCQ was positive, the heart failure reduction, hospitalization was also secondary outcome, a positive. In fact, they also had some mortality reduction. The problem is that on the registry data, they have some significant complications. And so people are scared of, that's why we don't have that here. People are scared of using that. 15% severe. And in fact, anecdotally, there are a number in some centers stopped doing them because of mortality. So there's a steep learning curve, but we'll see. Again, these things will develop. Again, you notice the differences: Kansas City and NYHA, 6-minute walk test, all of that in favor of the valve. So this compares essentially the two trials. Now, how about how do you do essentially put this all together? So let's say we have a secondary tricuspid regurgitation. How do we approach this? Multidisciplinary team. So initially, do your standard medicine workup, the standard medicine treatment. Be a good internist, right? So optimize GDMT. Make sure the pulmonary hypertension, atrial fibrillation, all of these things are optimized. Now, after all of that is done, you go to you move on now to the next step, and the heart team sits down and says, okay, low surgical risk, maybe we send them to surgery, right? No, the surgical risk is not so good. Now we want to try to decide if we can offer the patient something else. And you essentially decide, can I repair this with transcatheter, or is this something that I'm not going to go into the details? This is the big picture, right? So you do all the standard GDMT, all the standard medical treatment, and then you bring the patient to the heart team after essentially optimizing everything, and decide surgery, transcatheter repair versus transcatheter replacement. And here's a quick graph on how what you do with the leads. You frequently may need to send these patients for surgery and remove that. You use a lot of multimodality imaging to determine the mechanism. Is that rupture? Is it that impingement? Is it essentially adhesion? Anything else? You decide if this is just, the lead is there, but it's not causing this, or the lead is actually causing this. And then you decide, okay, the lead is causing this. Can we remove the lead? Yes, maybe you can. If you can't, can we offer them something else? So again, a multidisciplinary team decision. Sometimes, in fact, you actually go in, and here's an example. So this is a lead adhesion, and you see significant TR. And what they did was they essentially did a valve replacement, a percutaneous valve replacement with Evoque valve. And notice the lead is now behind the valve. So they crushed the lead essentially to the side. The lead is still functional, but the TR is significantly reduced. Okay, so I think I'm coming to the end of the talk. So let me quickly, wrap up the vignettes. So the first case that we had was the atrial secondary TR, right? It was mostly atrial fibrillation. How do you treat that? Again, standard GDMT, right? You do that. You offer them AFib ablation, AFib treatment, right? Catheter ablation is probably the best approach to do that. And then if that's not adequate, then you can decide. Of course, the technical parts about the dilation of 5 millimeter, the gap of 5 millimeter, annual dilation 45 millimeter. These are the things that makes you decide, okay, TriClip is actually a good choice. If the valve is significantly dilated, you're not going to be able to grab these two leaflets and pull them together. So that's sort of a very simple concept. That number is a gap of 7 millimeter. So just so you know why the TriClip here is a good option, lower risk than Evoque, essentially that valve replacement. And so nowadays, we have a lot of atrial secondary, TRs because of, the obesity and diabetes causing a lot of atrial fibrillation, HFpEF causing a lot of this stuff happening. So it's a rapidly growing phenotype, mostly in older women, atrial fibrillation, preserved ejection fraction. And so, offering them TriClip early is a good idea. Here's the lead associated. What would you do with that? I showed you a case. In the interest of time, I'll just stop there, but you essentially go with, the team, you remove the lead and you can offer them a valve. Sometimes you remove the lead and things are fine. And then you can go and put a leadless, device from then on, right? And things are fine. Sometimes you do all that and you still have significant TR and you have to decide what to do about that. And finally, the ventricular form is essentially GDMT. Do your CRT if you have to, if you can do that, right? Optimize the secondary pulmonary hypertension. All of that is done. And now, of course, this Evoque here, as opposed to Triclip is because of the anatomy. So notice the gap of 7. Again, this is nothing majorly important. It's just a matter of decision between triclip versus this, the valve replacement. Of course, we don't have the evoke here, so we have the triclip. Here's a case that I was involved. So these cases are a lot of fun. Sometimes they're 2 or 3 hours. So notice a severe tricuspid regurgitation right over here. And so this is a new field of interventional echocardiography. Notice a lead over there. That's severe TR. So here's again, I can make this work. So this is inside the stomach. Notice that lead is sitting right over there. We felt like this lead was impinging. Sometimes you need CT scan to decide adhesion versus impingement. We felt like the impingement was essentially the main mechanism. The CT was not performed. And you do a lot of 3D, essentially, echocardiography to do these procedures. So here's the device. And notice that the tricuspid valve is over here. On this side, again, you see this multiplanary reconstruction. The device is essentially approaching the valve. You make a decision. Here's the device. Here's the valve inside the stomach. And you decide, okay, so this is a good position. If you remember, there was that line, that coaptation line. You want to be vertical to a coaptation line. Because again, you think about it, you're going to grab these 2 leaflets. You want to make sure those forces are perpendicular to that line of coaptation. That is going to give you the best outcomes. So now we're happy with this. So now we're trying to grab those leaflets, as you notice. And eventually the device is essentially deployed. And we went from, this was essentially a 5+ torrential TR down to mild to moderate, so between 1 to 2+. We could actually do perhaps another, but the team decided to stop there. Okay, I'm going to stop here and open this up to questions. Thank you.
Thanks so much, Shahab. So interestingly, a few years ago, as you'll recall, one of the ways of dealing with the severe, it was protein losing enteropathy if it was a child, but if it was an adult, they get cirrhosis from this. And then the surgeons would say, it's too late, we can't do anything, child's class D, we're not doing anything, and the patient is going to have to pass away. So hopefully we're beyond that. We have the devices. But one of the devices that was supposed to take the pressure off, literally, was the atrial septostomy valve, one-way valve. It looks like that's like gone away.
That trial was, the first one was negative, and I know they're still working. There was a subgroup in there that showed some signal positivity, and I'm pretty sure they're actually doing another trial looking at that subgroup. But the first trial, it was essentially mostly HFpEF, and I think it was the lead PI was a Mayo. But it was about 600 patient study and was negative. But there was this subgroup that now they're looking into.
I see. Seems like it would help improve symptoms, but a long-term bad idea. Send the blood to the other side.
But it's good that again they if you're able to do randomized trial, that's best. I mean that's the bottom line. These trials are the ones that I showed you, they're all essentially randomized, but they're not blinded. It's impossible because you have to intubate the patient. I mean, think about it. You're going to do intubate the patient and put a 24 French catheter in the groin as a sham. Nobody's going to do that. I mean, you're just not going to do that, and nobody's going to be willing to. No IRB is going to accept that. So I think these trials are going to be, randomized, but probably not blinded. So people do have issues with those. Plus, you notice this is all KCCQ, this and that, mortality. We're not quite there, but it certainly makes sense for. I mean, at least from the symptomatic standpoint, patients who are very symptomatic, you've got to say, okay, we do medicine either to make people live longer or have better quality of life, and we can do that part. And hopefully we'll show, beyond our observational data that keeps saying, it is bad, it is bad, it is bad. Hopefully at some stage we'll be able to prove that in a randomized trial.
Other questions?
Yes. I'm not sure if I got it correct, but in a case where a patient is having pulmonary hypertension with TR, or let's say the patient has an implantable lead. So would you still go for a TriClip or would you
So-
prefer an EVO?
Right, first you want to try to optimize pulmonary hypertension. And as far as the lead is concerned, figure out what is up with the lead. Sometimes with those leads, you know, as the example I showed you, you make the decision is, okay, you know what, we're going to try to do a TriClip. But that is variable as to how you approach that.
Thank you.
Dr. Cook had a question.
Chris? So for the generalist in the crowd, as a primary care physician guilty of ignoring the tricuspid valve for the last 20 years, what I would love to know is any, and I think this is a moving target, but sort of rules of thumb in the primary care setting or even folks admitted to the general wards. We initiate GDMT, we optimize it to the best of our ability. Obviously, when it's not going well, it's a trigger to refer to cardiology. Is there also a trigger in a relatively asymptomatic or asymptomatic on medical therapy, at least, situation? Is there a trigger in which we should still, just based on echo results, be referring to cardiology?
Yeah, if you see that, longitudinally the TEER is worsening, I think it's good to have a discussion. And perhaps keep an eye on that. Again, it was always, okay, it's tricuspid regurgitation, don't worry about it, but the standard practice on the left side is always, if it's moderate, every 2 years do an echo, and obviously educate the patient about the symptoms, and if severe, think about once a year, and so on and so forth. And I think we should do more of this, because these, in internal medicine, you always have longitudinal relationships. So now that we have these essentially, devices, I think watching them, educating them, and of course monitoring that longitudinally is going to be helpful.